All right. Good morning, everyone. Thank you for joining us this morning. Um, Today we have Dr. Elizabeth Coons, who's an associate professor in neurology at Mayo. Dr. Coons received her medical degree from University of Iowa and went on to complete residency at Mayo in neurology, which was followed by 2 separate fellowships in movement disorder and autonomic disorders. She's currently serving as program director for the neurology residency in the same institution. Her research interest centers on autonomic dysfunction and synucleinopathies, which she will be telling us a lot about today. Dr. Kuhn is an active member of a number of societies, including the American Autonomic Society and American Academy of Neurology, where she serves as a chair of autonomic disorders section. She's also the chair of the UCNS Autonomic Disorder Examination Committee. Another of her interests is the history of neurology, which is a very important and interesting topic that's often overlooked. She served as vice chair of History of Neurology section in the AAN and has received the AAN's Lawrence C. McHenry Award in the same field. Dr. Kuhn, thank you for joining us today, and we look forward to your talk. You can proceed.
Thank you. I'm really honored to be here, and thank you for the very kind introduction. I want to make sure I get the right screen shared. So Johannes, I'll ask you to confirm for me.
Sure.
All right. Does that look good?
Yes, perfect.
All right, excellent. It's about 50-50 if I get the right one up or not. So I really appreciate the opportunity to talk with you all this morning, and especially about autonomic disorders. I have no disclosures. And really, this is my goal for the talk. Often when I interact with people and talk about autonomic disorders or say I'm an autonomic specialist, I hear an audible groan or just, why would you do that? And it takes me back because it's a very enriched specialty to practice. But I think there's a sense of misunderstanding, if you will, of the autonomic nervous system. And in trying to understand that, it may be similar to this neurophobia that people talk about neurology. And of course, we've gotten over that because we are neurologists. But there may be some similarities in that this autonomophobia, if you will, can be hard to perhaps localize, and sometimes vague complaints from patients. There can be overlap with a number of different organ systems. And as neurologists, we often like to localize and use a timeline to come to a diagnosis. And I hope today that I'll give you the tools to be able to do that for autonomic nervous system complaints as well, to be able to break them down systematically, think about central versus peripheral disorders, think about dysfunction versus failure, and then talk about some of the exciting things going on as well. This is the outline of the talk today. We'll start with getting back to some of the basics in that autonomic nervous system before going into the autonomic failure, autonomic dysfunction, and treatment possibilities. So let's move ahead into the autonomic anatomy and then how we specifically test the autonomic nervous system and the approach to autonomic nervous system disorders. So I can see where the autonomic nervous system can be daunting. It's everywhere. It's involved in automatic, unconscious, and involuntary functions for homeostasis. And in general, the range of physiologic functions are ultimately necessary for human survival, allow us to interact with the external world in a wide range of conditions. And it works closely with other organ systems as well, like the slow-acting, long-acting endocrine system, also more fast-acting, short-lived effects like visceral smooth muscle function, vascular beds, and secretion of a number of different glands. So if we try and break those down systematically, we can start by talking about the sympathetic nervous system. traditionally our fight or flight system. And this has a unique way that it does patterns of specific units. So it's not that the entire sympathetic nervous system is activated all at once. You know, of course, when we wanted to go to the bathroom, we wouldn't want our pupils to be activated as well, or sweating to occur. And similarly, if we're running from a bear, we want our blood pressure up, our heart rate up, and you know, that genital urinary system kind of off in the background. So it's these functional units. Dr. Benaroche, who taught me, described them as piano chords with specific interactions and groups of systems that want to be activated based on the specific stressor. In contrast to that, the parasympathetic nervous system really, I think, is the unsung hero of the autonomic nervous system. It is doing so much in the background. We really want this to be the primary driver of the autonomic nervous system. It again has these cranial effectors and a lot of visceral effectors as well. And it is actually more of the fast acting of the two systems of the autonomic nervous system between parasympathetic and sympathetic. So I'm going to talk a little bit more about this parasympathetic pathway. And as we learned in medical school, it really largely originates in that brainstem and sacral regions, and with those characteristic nuclei 3, 7, 9, and 10. The vagus nerve is one of the kind of the longest output nerves that we have in our nervous system, doing a myriad of different functions, including that cardiac output and to the gut. And some important things to think about from an anatomical basis and physiologic basis is here the ganglia are close to the effector organ. The neurotransmitter in the parasympathetic nervous system is acetylcholine, both at the ganglia and at the effector organ. When we think about parasympathetic nervous system symptoms, then, if there's damage or failure, then we have these characteristic Sicca syndrome, that slow gut, constipation. Tachycardia can come out because that sympathetic nervous system is sort of unmasked, if you will, and that heart rate variability declines. And also sexual dysfunction. Whereas if we see hyperactivation, we see kind of the opposite of this. When we think about the sympathetic nervous system, this is our thoracolumbar system with outputs coming from the T1 to L2 region. And here, notice the ganglia are quite close to that spinal cord, with the effector organs, with the nerves going out then to the effector organs. Just like the parasympathetic nervous system, acetylcholine is used at that ganglia, but the effector organ neurotransmitter tends to be norepinephrine, except in the sweat gland, where acetylcholine is again used. So if we think about sympathetic nervous system and damage to this system, or reduction in activity of the sympathetic nervous system, you see a drops in blood pressure. This can manifest by postprandial lightheadedness as blood pools to our gut after eating, kind of brings down that circulating blood volume. Patients can comment on coat hanger distribution pain as our big strap muscles that are used to keep us up really get ischemic because they're not getting enough blood flow in that hypotension. Heat intolerance because sweating is affected. And then some more nonspecific symptoms as well, again with sexual dysfunction. In patients with hyperactivity of the sympathetic nervous system, we see, again, the opposite. So often pallor, this fine high-frequency tremor, this hypertension, tachycardia, pilar erection, and excessive sweating. So if we can break down these specific symptoms and signs that we're seeing in our patients when they come with various autonomic complaints, then we can go down a different pathway into how to best approach them. So autonomic function testing, and what I'll share today, a lot can be done at the bedside too, or there's corollaries to bedside testing. And if everything really looks normal, patient certainly has those symptoms, it's termed autonomic dysfunction. So things we're thinking under that category would be iatrogenic effects from medications, hypovolemia. Syncope actually falls in this. It's a transient dysfunction of the autonomic nervous system with a baseline normal background. and then postural tachycardia syndrome. Whereas if we have abnormal function testing, or we know that there's damage to that autonomic nervous system, characterized as failure. And with that, we can go into more central causes versus peripheral causes, thinking from the ganglia out to that autonomic nerve. So now I'm going to talk a little bit more about testing that autonomic nervous system. And one of the, I guess, the internationally accepted way to do this is an autonomic reflex screen. This involves checking pseudomotor function, so sweating function, cardiovagal function, and cardiovascular adrenergic function. I'm also going to introduce a thermoregulatory sweat test because I'm going to be talking about that later in the talk and how we use them together. But the TST is something that assesses both that central peripheral system. It's not used as widely as the autonomic reflex screen. When we think about this thermoregulatory sweat system, I think that the sweat test really helps us understand that pathway. So the output's largely in that hypothalamus. Again, this is a sympathetic output, so it's coming down into that thoracolumbar spinal cord region through that intermediolateral cell column, going out to the ganglia, and again using acetylcholine at the sweat gland. What we do in the sweat test is we have patients lie on a gurney, cover them in an indicator powder, alizarin red, that is a typically yellow-orange powder that turns purple when it interacts with water or sweat. So then patients are rolled into this heat box, and the temperature is kept at about 120 degrees Fahrenheit with a 40% humidity. We closely monitor the oral temperature, akin to that core temperature, until it rises up to 38 degrees Celsius. Look for the areas that are sweating or not sweating, and we can quantify that as percentage anhydrosis. So really the TST is checking that entire system from central to peripheral. And if there's a break in there, either any of those areas, and it's going to be an anhydrotic region. Contrast that to the QSART, or the quantitative pseudomotor axon reflex test, which is really just looking at that postganglionic sympathetic nerve. Dr. Lowe, one of my mentors, pioneered this back in the 1980s, and this sweat capsule is used to iontophoresis acetylcholine from the outer ring. There's a barrier ring, and then from that internal ring, the amount of sweat that is captured is measured. So we can look at that sweat response. And really, it's an activation of the sweat gland from acetylcholine, some retrograde activation of the neighboring sweat gland to lead to that sweat response. There are typically 4 sites done, and I'll show that in a few other slides. Next thing we check is cardiovagal function. So really looking at that parasympathetic nervous system. And with the first thing we do is heart rate to deep breathing. So this timed inhalation and exhalation. This sinus arrhythmia is really due to a number of different reflexes, Heron-Brewer, Bainbridge, and the Barrow reflex. Really what we see with inspiration, shown in the blue, the heart rate should rise. And then with exhalation, the vagus nerve kicks in, pulls that heart rate down, and we can measure the 5 consecutive responses to do an age-mediated control. Compare that to the control. We can also look at heart rate response to Valsalva. So for Valsalva maneuver, patients are holding pressure, and this blocks venous return in the chest. So with that block of venous return, that blood pressure drops. So with blood pressure drop, sympathetic nervous system is activated, so heart rate comes on. Once that blood pressure is released and is back up to that baseline, the vagus nerve turns back on, pulls that heart rate back to its baseline. And we can measure that with a ratio from this max to minimum, again, based on age-related controls. So there we can check the vagus nerve, largely at the heart. And we can look at sympathetic nervous system function, again, through this Valsalva maneuver, and looking at beat-to-beat blood pressure responses. So using that beat-to-beat blood pressure response, we can really see the waveforms that develop with that Valsalva. So by the initial kind of increase or holding that Valsalva, we get a phase 1, more mechanical. And then as preload is blocked, that early phase 2 develops, kicks on sympathetic nervous system. We see vasoconstriction lead to an increase or late phase 2 here. Pressure is released, so another mechanical fall. But like I said, that sympathetic nervous system is somewhat slow. So there's continued vasoconstriction, if you will, and we see this overshoot of blood pressure or phase 4. So in patients with sympathetic failure, we tend to see a blunting or absent late phase 2, and often an absent phase 4 overshoot as well. Another way to check sympathetic function is on tilt. So here the patients are flat for about 5 minutes. There's a tilt up to 70 degrees, and this is a passive tilt. And upon transitioning to that posture, we know that gravity causes the blood to redistribute away from the head, thoracic vasculature to the splanchnic and lower extremities. So within 3 minutes, almost a liter of blood, or approximately 10% of blood volume, is displaced downward. That triggers that sympathetic nervous system. We can see some kind of sympathetic activations occurring here, but largely keeps that blood pressure stable unless there's been damage to the sympathetic nervous system or that baroreflex we'll talk about. And then, of course, if blood pressure drops, then that heart rate should kick up in a compensatory way. We use the orthostatic hypotension criteria is 20/10 with standing, because with active standing, you're still using the muscle pumps in the legs, whereas that requiring a higher degree of blood pressure drop when done on at 70 degrees or a passive tilt, so 30/15. And then we can discern if there is orthostatic hypotension. Is it due to a neurogenic cause or a non-neurogenic cause? So in this patient, we see this significant blood pressure drop. So going from about 180 systolic down to almost 80 systolic during that tilt. And you can see that the heart rate is really stable, so minimal increase. The NYU group did a fantastic study looking at a well-defined population of patients with orthostatic hypotension, neurogenic causes, and non-neurogenic causes. And they showed that in patients with neurogenic causes, be it central or peripheral, there's really a blunted heart rate response, even more so in patients with peripheral causes, and then led to a specific ratio. So it pretty much says that if the amount of blood pressure drop that we see on tilt, the heart rate needs to at least be about half that. So if this was a 100-point drop, we'd expect this heart rate response to be 50 beats per minute. Since it's certainly less than that 0.5 ratio, then that fits with neurogenic orthostatic hypotension. And what is nice, though, is you don't need a tilt test to do this because it's been validated also with active standing. So just bedside blood pressure readings for 3 minutes, you can still use this 0.5 ratio to determine if the patient has neurogenic orthostatic hypotension based on that blood pressure drop and compensatory heart rate rise. So we've gotten through that testing. So now we can go down more the pathway of these specific types of autonomic disorders. So first, talking about autonomic failure. So if we're going down the abnormal autonomic function testing pathway, we can look at both central or peripheral causes. So I'm going to switch gears a bit and bring up a case. So this was a 57-year-old gentleman. He came in for labile blood pressure. He had a past history of hypertension and also had oral cancer radiated about 5 years earlier. He'd done well from that, but just was not thriving at home. He had, again, pre-syncopal symptoms in that classic coat hanger distribution, usually triggered by orthostatic stress or even eating. You can see he had a significant blood pressure drop on just active standing in the office and really minimal heart rate response. So we have some concern for autonomic failure already. His autonomic function testing really confirmed this, but there were some unique features of the testing that helped us come to the diagnosis. So here, when he's breathing in and out, we see this variation in heart rate and really it's normal for his age. Yet when he's doing the Valsalva maneuver, we see a significant blood pressure drop, no activation of that late phase 2, no phase 4, and it really takes almost a minute for his blood pressure to get from the nadir of phase 3 back up to baseline. So that portends, again, a drop in blood pressure with that prolonged blood pressure recovery time. But even with that significant blood pressure drop, there's really minimal heart rate rise, and that's really picked up by that blunted Valsalva ratio. So when we see this discordant normal heart rate to deep breathing and an abnormal Valsalva ratio, that clues us into specific pathway or mechanism. And based on what we saw on that blood pressure recovery time, again, he had both supine hypertension and significant drop. Now, interestingly, with this, he had really no symptoms on tilt, which is often common when patients have a blood pressure drop, but they stay above about 90 millimeters mercury systolic. That's typically enough cerebral perfusion pressure so that patients are asymptomatic despite that magnitude. We did pseudomotor testing too, and at those 4 sites, so the arm and then 3 sites on the leg, he had nice sweat volume, showing that there's no postganglionic involvement. And what was interesting is TST also helped confirm the diagnosis. You can see this area of anhidrosis that corresponds to his previous location of radiation. So this clinical syndrome fits with afferent baroreflex failure. And I think that it really highlights this baroreflex. My residents tease me that I'll do anything to bring up the baroreflex as it's such a fantastic reflex. And I guess every neurologist has their own favorite reflex. But this baroreflex is always working in the background and keeping our blood pressure stable into these minute variations in blood pressure and heart rate. And if we think about the specific regions, and what was affected in this gentleman was largely the sensor. So the baroreceptors at the carotid sinus, perhaps 9 and 10 as they're coming into the brainstem. And we know the first transit site is that nucleus of the solitary tract. There's then activation, if a blood pressure drop, of that sympathetic nervous system down through the spinal cord, causing that increase in total peripheral vascular resistance with vasoconstriction, brings blood pressure up, and then we can see the modulation and turning off that. Going along with this, though, is heart rate responses. So if blood pressure is down, then it's going to reduce the vagus outflow so that heart rate can come back, and converse can go along with those blood pressure and heart rate variations. What's interesting in baroreflex failure is that these nerves are affected, bringing that input into the nucleus of the solitary tract. So the sympathetic outflow is clearly impaired, resulting in blood pressure drop. But what we saw in that heart rate to deep breathing showed intact outflow through the vagus nerve. And that was what was picked up on the normal heart rate to deep breathing, as it's a different mechanism than what we see in that Valsalva pathway. When we think about causes of afferent baroreflex failure, most common is neck radiation. These patients tend to come on over years after the radiation. There can also be more acute onset, and typically this occurs in patients who've had neck surgery or neck trauma, but a number of other disorders can be related as well. And Dr. Lamont, when he looked at afferent baroreflex failure, really compared the time course to patients who had biopsy-confirmed radiation-induced plexopathy. Of course, we can't really biopsy the baroreflex, or baroreceptors, if you will. So we have to take clues from areas that can be biopsied, and it really seemed to fit well with the changes seen from the radiation-induced plexopathy. So we suspect it's a similar mechanism with oxidative stress, chronic inflammation, fibrosis, and microvascular changes that contribute to the disorder. Of course, these are the clinical symptoms, similar to what our patient had. As I showed, that vagus nerve is still intact for the output, so there can be episodic bradycardia as well. And then management, we want to make sure more long-acting medications are used so there's not a chasing up and down effect. Now I'm going to move down into that spinal cord. We're going to talk about a patient of mine, so a 56-year-old woman with congenital arthrogryposis. You can see significant bony abnormalities leading to quadriparesis. And she came in because she said, Dr. Coon, I'm having these episodes where I get really flushed and the nurse checks my blood pressure and it's 220, and they're occurring about every week. And so I was thinking, okay. And I got a little more history and I was thinking about, okay, what is the most likely diagnosis? Is this hypertensive emergency, urinary retention, stroke, or autonomic dysreflexia? And on talking with her, she said, these only occur on Thursdays at 10 a.m. when my nurse comes in to do my catheter change. So it really fits with an autonomic dysreflexia picture. And for that, we know that the specific spinal cord level of injury can contribute to a propensity to develop autonomic reflexia, and specifically at T6. And I'll go over those specific levels in a bit. And that T6 level is really important for a number of reasons. So that the source of this autonomic dysreflexia tends to be kind of genital urinary, but could be a number of different things. What happens is there's a pain reflex or response, but it's in the areas where patients are typically insensate and triggers a local sympathetic response. Now, the vascular beds are innervated below T6, so this local sympathetic response causes a massive sympathetic response with vasoconstriction in those visceral beds. The vasoconstriction, we see hypertension, and then the baroreflex is activated. With that baroreflex activated, that hypertension is going to cause the heart rate to come down or bradycardia, and then the baroreflex should be decreasing that sympathetic outflow, but the signal is stopped or blocked at the level of injury. So you have this persistent hypertensive response with bradycardia. This can be a significantly concerning for patients in a medical emergency. And I like this kind of depiction of it from Vaughn Macefield's group. So this is a patient where they're infusing saline into the bladder. And with that, we see that pressures in the bladder remain largely stable till they hit a specific threshold and then begin to rise more acutely. Blood pressures then rise, but we see in consistent with vasoconstriction from skin blood flow readings and that heart rate decline. So a real-time picture of what can happen to trigger an autonomic dysreflexia episode. Of course, prevention is best. And for our patient, she really gave us a clue. It was just pre-treating, if you will, before the catheter changes. So now I'm going to move on to the synucleinopathies. As Johannes said, an area near and dear to my heart. And this falls in that central autonomic failure, largely affecting cortex, brainstem, and some spinal cord. We know the synucleinopathies are a group of disorders characterized by abnormally misfolded alpha-synuclein, can affect the central and peripheral nervous system, and it's the differences in the cellular location and the pattern that leads to the distinct syndromes. The Lewy body disorders we know of as PD, DLB, and pure autonomic failure, and MSA is characterized by those glial cytoplasmic inclusions. They really have shared clinical features like RBD and a lot of autonomic dysfunction in a number of them. The Lewy body disorder is also characterized by anosmia. So this next patient was a 62-year-old man. He came in for autonomic failure, had a 7-year history of lightheadedness that had been gradually progressive. In addition to that, he endorsed constipation, sexual dysfunction, some urinary urgency, but overall hadn't had any incontinence. Neurologic examination was just stone cold normal, as was his imaging. And when we did autonomic function testing, though, we saw significant sympathetic failure with that absent late phase 2, again, some prolonged blood pressure recovery time, and orthostatic hypotension, just barely meeting that criteria, but you can see really minimal heart rate rise consistent with a neurogenic cause. had about 11% anhidrosis and preserved postganglionic sweating on QSART. So in thinking about this diagnosis, I would say with the normal autonomic, with a normal neurologic exam in the presence of autonomic failure, likely fits best with pure autonomic failure. And pure autonomic failure is this Lewy body disorder that should have predominantly peripheral alpha-synuclein inclusion. The criteria is that you really just have to have orthostatic hypotension, and the autonomic failure can be severe. Now, patients with pure autonomic failure, I think what is important is that they can later develop motor or cognitive signs. So we term this progression or phenoconversion. And there's some there's some specific things that we can look at, though, when we're initially seeing them presenting with PAF. Here's kind of 3 years later, and he did come back. He had tremor, rest tremor, bradykinesia. So really everything, fitting now with Parkinson's disease. And of patients who have this PAF phenoconversion, there's really different rates that have been put out in the literature. And even some suggesting it may be closer to, say, even 50% as well. So we looked at it in our pure autonomic failure cohort of about 275 patients. And we had about 76% of patients with PAF still retained this PAF phenotype and really split evenly between those who went on to develop MSA versus DLB. And then we can look at these specific predictors of phenoconversion too. So what was interesting is that subtle motor signs at presentation really predicted that patients would go on to develop MSA. Also, we saw this in patients with DLB. And really in MSA, it looked more like a central type pattern, which is what we'd expect from a pathophysiologic side. And then more of a peripheral pattern on the DLB side. So we can do these specific clinical calculators then, and so to use that to give information to our patient of the probability we expect that they may go on to develop, say, pure autonomic failure or from pure autonomic failure to MSA or Lewy body. So say if a patient comes in with some subtle motor signs, say they're not moving their arm so much, their supine norepinephrine is greater than 100, consistent with a central disorder, and they already have urinary incontinence, it's almost a 98% chance that they will go on to develop multiple system atrophy. Of course, that doesn't say when that occurs for any one given patient. For Parkinson's disease, I want to highlight the autonomic features really can have a significant range from mild to more severe. One characteristic thing about the bladder, though, it tends to be characterized by overactivity, so more of an urgency frequency type pattern. And the thermoregulatory dysfunction is interesting. And James Parkinson's even noted in that in his original description, in that patients often had excessive sweating on the side of the body that had the more severe motor impairment. And what now in the post-levodopa era, what we tend to see is patients are coming off of their levodopa classically at night, then they tend to have more hyperhidrosis episodes. And so that can be a clue to adjust their levodopa regimens. Patients with dementia with Lewy bodies, I'd say, have more of a moderate degree of autonomic failure. Their thermoregulatory dysfunction, when we look at them on sweat tests, seems to be kind of more middle degree, and say patients with PD tend to have lower percentage anhidrosis. They're more in the middle. And then we compare that to patients with multiple system atrophy who tend to have severe widespread autonomic failure. Patients with MSA, we also have some of these red flag features with that upper motor neuron syndrome, chin on chest deformity, and often early and severe dyskinesias when given levodopa. Here's some of the classic imaging findings in MSAP. So we can see T2 hyperintensity outside the lateral putamen, also some GRE signal in the similar area. Whereas in MSAC, we see the hyperintensity of the crossing pontine fibers, more of that cerebellar and pontine atrophy. There's been a lot going on in MSA recently, but you probably saw the MDS criteria was revised. So we previously had possible, probable, and then the neuropathologically defined or definite. Now we have clinically established, which is the highest degree of certainty that we can use when patients are living, and then clinically probable is a bit of a lesser degree, so a little bit less sensitive and specific. There's also a new criteria that's a prodromal, and that picks up these patients with pure autonomic failure, but also patients with REM sleep behavior disorder could fall in that possible prodromal MSA category, intended to be more of a research type category. MSA pathogenesis really has come a long ways too in the last several years, and some exciting advancements that have shown that it's likely due to a prion-like cell-to-cell spread of abnormally folded proteins. And then these aggregates are then released and can potentiate this similar aggregation of other alpha-synuclein in different areas. And so we're learning more about these different strains too in the Lewy body disorders versus MSA and how these oligomers look different. And that's something that's been capitalized on in biomarker studies. So this was a patient then, that the PIF patient that I ordered this skin biopsy. And you might say, well, if you thought the patient had pure autonomic failure, why did you need a skin biopsy? And part of that is because the papers by Dr. Gibbons and the Beth Israel group show that specific signatures of skin biopsy deposition can help predict, say, MSA from Parkinson's disease. So when I saw the patient with pure autonomic failure, I wasn't sure if this gentleman was going to go into MSA or PD. We did our calculators, and I was hopeful that this would kind of help sort that out for us. Now, this is not kind of clinically available quite yet, but in terms of the MSA versus PD, just more of the synuclein positive. But what we recently just had published, or was published in the last week in the autonomic field, was the SYN1 and the use of really looking at really the numbers of how effective it is at picking up alpha-synuclein, which overall it's pretty good for picking up synucleinopathies. There still are a few patients with false positives, but overall, I think in the future, if there's question of synucleinopathy or not, this can be useful. Spinal fluid is actually really a promising biomarker as well, because those different oligomers that we're seeing between the Lewy body disorders and MSA have different kind of aggregation characteristics, if you will. So this is on protein misfolding cyclic amplification. There's also work kind of in RT-QuIC type area to try and distinguish the Lewy body versus MSA disorders, really all getting towards an earlier diagnosis for these patients. I'm going to touch on some additional central autonomic disorders. So paroxysmal autonomic hyperactivity, something that we tend to see in our patients in the ICU or those with traumatic brain injury. And here there's fever, tachycardia, hypertension, tachypnea, hyperhidrosis. So again, of that excessive sympathetic nervous system activity, we think it's perhaps a disinhibition of those sympathetic excitatory regions of the brain. Our autoimmune colleagues also have a potential to see patients with a number of autonomic disorders like the NMDA receptor encephalitis. And this NMDA receptor encephalitis is unique because it also has distinct phases. So initially, some of the prodromal symptoms may be excessive sympathetic nervous system activity, so that tachycardia, hypertension. But as the disease becomes more severe, and especially if untreated, it can lead to kind of a damage to these areas over time. So eventually these patients then develop more orthostatic hypotension kind of later on in the diseases. Patients with MS also have frequent autonomic symptoms, and this goes along with the different areas in that central autonomic network that can be affected by MS. And then epilepsy as well, especially patients with temporal lobe seizures may present with symptoms characteristic by either typically sympathetic hyperactivity. Even isolated autonomic symptoms like piloerection has been attributed to seizures. And then stroke, there's a fair amount of overlap as well. So certain patients, we know, especially right insula or left parietal insular region, strokes can lead to cardiac arrhythmias. Also, elevated troponins often seen in this group, and thermoregulatory dysfunction may be affected. This is important to note because it can affect morbidity and mortality. So now we've hit largely those sympathetic disorders. Let's do a few kind of more peripheral examples. So this was a woman referred for lightheadedness. She really had a 5-year history of presyncope, also a kind of burning pain in the legs, Sicca syndrome, and length-dependent reduction to sensation. So on her QSART, the red is forearm looks great, but all of those lower extremity sites were either absent or significantly reduced. So in this in this lady, I would say that the most likely cause, especially with that Sicca syndrome, fits with Sjogren's syndrome. And with Sjogren's, we know there can be significant percentage with extraglandular manifestations, more commonly affecting women. And it falls under these different causes of peripheral autonomic neuropathies. And this by no means, I mean, this is a lot to take in, but I wanted to just highlight the different categories in metabolic, toxic, infectious, immunologic, hereditary, and idiopathic. And unfortunately, we only have about a 50% success rate at being able to pick up the causes of some of these autonomic neuropathies. Now, certainly the most common is diabetes, and often the autonomic involvement is early. Typically also presents with the distal small fiber neuropathy and is important to pick up because of the increased morbidity mortality. So here we can see really blunted heart rate to deep breathing in a patient with diabetes, showing that that vagus nerve is often involved early. Now, it's not only just this hyperglycemia that can lead to autonomic nervous system dysfunction, rapid correction of blood sugars, so a decrease in 2 to 3% over 3 months can also lead to a significant autonomic neuropathy or treatment-induced neuropathy in diabetes, often with significant pain that's associated with that. Amyloidosis is another classic autonomic cause of autonomic neuropathy. And here you can see there's a number of different causes or another number of different organ systems that can be involved. And I would say that in patients with amyloidosis, we often see orthostatic hypotension from the peripheral neuropathy, but the heart failure may be contributing as well. So now we've really made it through our autonomic failure cases. And in the last few minutes, I do want to spend some time and talk about autonomic dysfunction. So now we have patients with normal autonomic function. And classically, these patients describe an orthostatic intolerance, and there's a number of different syndromes that can overlap with that. So a case here is a 32-year-old woman, and she had palpitations on standing. Her history was of flu and had been on bed rest for about 10 days. Now, coming off of that, had a lot of shortness of breath, reduced exercise tolerance. She was a bit hypermobile and had a fine postural tremor on exam. So on her tilt, we can see this excessive heart rate increment, whereas blood pressure was really preserved. What's notable here is the significant oscillations as well. So here, I'd say most likely diagnosis is postural tachycardia syndrome. So what is POTS? It's when patients meet that greater than 30 beat increment, either on tilt or standing in the office, and also have symptoms of orthostatic intolerance. Now, some patients may not quite meet that 30 beat per minute increment, and so they're termed more mild orthostatic intolerance. POTS is classically more of a disease that affects women. It's fairly common, and there's a number of different mechanisms that contribute to POTS. We can kind of use that then to do specific subtypes. So, and specifically, this hyperadrenergic POTS tends to have specific features, whereas in neuropathic, say there's been damage with a limited autonomic neuropathy versus other kind of additional causes that can contribute. And definitely not mutually exclusive. So I want to highlight this hyperadrenergic POTS, which I think is what is affecting our patients. So we have too much sympathetic nervous system activity. We can check norepinephrine levels, and here we see greater than 600 as contributing to that hyperadrenergic POTS. A lot of excessive symptoms associated with that. And secondary causes may be due to like mast cell disorders. In neuropathic POTS, we've seen more of a neuropathy, and this may be triggered by, say, a virus. Typically comes on subacutely following a virus, may have some ganglionic antibody elevations. This is how we typically make the diagnosis of POTS. It's really history, physical, ECG, blood tests, and additional tests as needed. Now, there's a lot of overlap, too, with what we're seeing with long COVID and with a myriad of autonomic symptoms being reported. Now, if you look at the mechanisms that have been proposed for long COVID, you can see there's significant overlap with what we think of postural tachycardia syndrome, and the symptoms definitely can overlap as well. Some of the studies that have looked at long COVID, unfortunately, they're fairly small, and everyone's using a bit different criteria, but it tends to have fairly similar features to POTS. Patients in this cohort by Dr. Novak in Boston had a lot of this POTS type symptoms, but what was different is that the patients with long COVID tended to have more small fiber neuropathy. They had similar cerebral blood flow data on tilt, but it was more the small fiber neuropathy that looked different in this long COVID cohort. I would say in our experience with long COVID, we didn't find, we found really variability. So some patients had significant symptoms, had normal autonomic testing. Others, we picked up more of that small fiber neuropathy, but interesting, about almost a quarter met that POTS criteria. So now in the last few minutes, I want to just highlight some treatment. Since we're talking about this dysfunction, I do want to always give patients with POTS hope and recommendations for how they can improve their quality of life. Often it's carefully looking at those medications, and reconditioning is the best route to success. Now, if a patient is actively having symptoms or orthostatic symptoms, be it from orthostatic intolerance or orthostatic hypotension, there's a number of non-medication things we use, so physical counter maneuvers, sending that blood back up to the head, getting that fluid volume up to about 2 liters a day. And on that fluid part, I also want to stress something: cold water boluses. So this is 8 to 16 ounces of ice cold water or out of the fridge, taken rapidly, almost like a chug. One of my favorite patients with dementia with Lewy bodies was having significant orthostatic intolerance and hypotension in the morning, but he had supine hypertension, so it was limiting our pharmacologic options. So I recommended this to have ice cold water at his bedside, take it before he got out of bed. And with his cognitive impairment, then every time he comes back in to see, he tells me about this miraculous thing that he does in the morning, taking the ice cold water, and it stabilizes his blood pressure, and he can go about his morning routine. Then there's, of course, increasing salt to hold on to that volume, and then compression. We talked about the vascular beds holding so much of our blood volume, but also the upper thighs are really important as well. I'll be honest, the compression up to the knees does not do too much, because we don't really pool that much blood, if you think, in that ankle area, unless someone has a lower extremity edema. Exercise is so important, and especially some resistance training added on to that lower body. And then elevation of head and bed, especially in patients with supine hypertension. The pharmacologic treatments for POTS can really can be helpful to sort of get them over the acute phases. Often the beta blockers are good for hyperadrenergic POTS. If there's a blood pressure, decline or tendency to droop, In the setting of neuropathic POTS, and mitogen can be considered. But overall, it's really exercise training, which is the most effective thing. And in prospective studies has been better than pharmacologic treatment, including the beta blockers. But it's got to be gradual. I tend to use the CHOP protocol, which is about a 9-month protocol to really get patients up to 45 minutes a day, most days per week. In patients with autonomic failure, there are a number of different pharmacologic treatments, and I like to think about it in terms of the Barre reflex. So what area is affected? Is it more kind of low volume and status? In that case, fludrocortisone can be helpful. Is it because patients can't really vasoconstrict or increase that total peripheral vascular resistance? And then more mitogen or droxidopa can be useful. Both of those, or all of those, have the potential for supine hypertension, and the timing of action is very different. For patients on mitogen or droxidopa, we really recommend that they stay flat for 4 hours, or sorry, they do not lie flat for 4 hours after taking the medication. So often I see patients who are mitogen 3 times a day, and it just pains me to see they're taking this, they're laying down at bed, they're sending these massive pressures to their brain that could lead to other damage. And then pridostigmine. And so if we think about pridostigmine, of course, we use it for other reasons in neurology. If we go back to our pathophysiology, the autonomic ganglia in the sympathetic nervous system use acetylcholine. So by increasing the amount of acetylcholine in the system, that's going to increase the transmission through the sympathetic nervous system. The studies really showed it increases diastolic pressure by about 5 points, but diastolic does a lot to contribute to MAP, so it may be just enough to keep patients doing things better upright. And often we use it in conjunction with mitogen. So we have done a whirlwind tour of the autonomic nervous system. We've gone through the different symptoms, how to test, and gone through the different arms of autonomic dysfunction versus autonomic failure and characteristics of that central versus peripheral, as well as a few tips on non-pharmacologic and pharmacologic treatment. I will give a shameless plug for our UCNS accredited autonomic disorders fellowship. There's now 7 across the country. We always tell our fellows, and sometimes our fellows tell us, that it's the best year of their life. So if there's any trainees interested, I'm happy to talk with them. And I thank you again for the invitation, and I'm happy to take any questions.
Thank you, Dr. Coon. I think there are some questions in the chat. The first question is from Brookdale Neurology. They're asking if the autonomic dysfunction, or when the autonomic dysfunction starts in patients with PD. Is it early on the stage or late on the stage of disease progression?
Yes, absolutely. So that's a great question. I would say classically, the autonomic symptoms tend to be a little bit under the surface early on. You might notice that you start levodopa and it brings blood pressures down about 10 points. So then you have to scale back some of these antihypertensive medications that patients are on. And then the autonomic failure can increase over time and become more problematic. But there's also a subset of patients with Parkinson's disease, and it largely overlaps with those that have pure autonomic failure and then go on to develop Parkinson's disease. So by definition, they already have severe autonomic dysfunction, and then they develop the Parkinsonism. So in those patients, it can be early on as well. What's tricky is that those patients with Parkinson's disease and severe autonomic failure really overlap with MSA. So that's where I see patients with more of this Parkinson's disease autonomic failure picture diagnosed with MSA, yet they'll have it for 10, 20 years. So I think a great question bringing that up. Oh, and then I see Roger Bannister. So yes, yeah. And I have so Dr. Lowe, one of my mentors, Sir Bannister, if you will. So I've I also can say that I have a different talk on pure autonomic failure specifically, and he did a lot to really differentiate autonomic failure in Lewy body disorders versus the central disorders, and how it's more of a peripheral disorder in the Lewy body disorders. So really fantastic contribution to this field. And from talking with a number of people who kind of overlapped with his career, I think he was also very humble and felt that what he had contributed to science and the autonomic nervous system even overshadowed that of running. I'm a runner, so I knew of him first as from that 4-minute mile, and I've got a couple books in the background too. So yeah, thank you for bringing up Sir Bannister. Oh, and then patients with migraine. Yeah, so there's significant overlap in patients with migraine and postural tachycardia syndrome. Of course, it's a similar epidemiologic group that can be affected. There's probably, sex and gender differences too that I don't think have been very well explored. What I tend to see in the autonomic side of things is, migraines can be really debilitating, and so patients often can't do their exercises as needed, and then that can further worsen the POTS, if you will. So we'll have to really focus on, say, that migraine therapy so that they can build back up that exercise tolerance to try and get the POTS symptoms under control. But yeah, there's definitely an overlap. Thank you.
I have a question. Do you think the fluctuations that in Lewy body that you see in cognition and wakefulness also apply to autonomic symptoms?
Yes, it can. And so I've queried in some patients. So, the caregivers call in, okay, and they describe these fluctuations. And so the first thing we do then is kind of ask them to check blood pressures. Is it high? Is it low? And what I've had is sort of a mixed response. And in most patients with the fluctuations, I haven't been able to correlate so much with blood pressure changes, because obviously there's things we can do to really address those blood pressure. But I'd love to hear what you see in your practice, and kind of the overlap that you see.
Well, one thing we see is lots of people, 85-year-old women coming in with syncope and who get the usual neurology, EEG, and cardiac workup with no etiology found. And then we sort of infer that maybe they have Lewy body disease based on other stuff, and just try to reassure them that after 2 workups, that's enough already. But that's all we can do.
Yeah, it's tough because when we don't find that correlate to these specific events. Saw Dima on there too. I've had the opportunity to work with Dima, so good to see you.
Dr. Coons, thank you so much for this wonderful talk. It's very good to see you too. I do have a question actually. It's kind of during the practice in the clinic, I often get this question regarding POTS. What is the prognosis? Will I be cured of it? Because it's kind of disabling for middle-aged or even younger women. So I'd like to hear your side of this.
Yeah, so it's a great question. I can say there's not great studies looking at that. And what I tend to see is it's based on the subtype. So patients with this neuropathic subtype often have this, completely healthy preceding viral illness and then severely affected by POTS. Those patients can really hard in that short term, but their prognosis overall as they recover tends to be quite good. Whereas patients with a hyperadrenergic POTS, I say we can do some medications to try and keep symptoms under control, but they may be dealing with some residual symptoms over time. Where we struggle the most is those with overlapping disorders. So overlapping fibromyalgia, just chronic fatigue, myalgic encephalopathy, and so if they're not able to really fully exercise and do that program, the prognosis isn't as good. So it's really a lot based on what they can do for therapies. Yeah, great question.
Yes, Brian and Vitka, adult neurology, patients with migraine often have severe nausea and vomiting, even without headaches. What is the autonomic basis of that? And
Wow.
what is the anatomy of that as well?
Yeah. Yeah, I don't know. I think about that. Could it be like a cortical spreading depression? Is it affecting the autonomic areas? We think about these central autonomic being kind of deep, or the insula particular. But I don't know. That's a great question.
Is there gastric dilatation accompanying the nausea and the vomiting? In other words, sort of loss of parasympathetic function?
That's a good question. If it's kind of more, it's a kind of an excessive sympathetic, if you will, or parasympathetic kind of manifestations. I don't know. It's a wonderful.
I also have
Thank you.
another question. Okay. Thank you so much for answering the first question about Parkinson's disease. Do you think, I mean, in your experience, do you think that presentation of autonomic dysfunction in earlier stages of Parkinson's disease predispose them to more severe outcome? And is it different in patients with tremor dominant versus akinetic rigid patients? Or, I mean, is there any data about that? Thank you.
That's a great question. I don't know of any data. And that's a great question. Do we see more of this autonomic failure in tremor predominant versus akinetic rigid? I'd say in my practice, I would think it's probably more in the akinetic rigid who then have a worse prognosis rather than the tremor predominant. But I don't know any specific studies looking at that. Yeah, thanks for bringing that.
That might be something you should.
Thank you so much. That was my thought process. I just wanted to make sure if there's any data. That's a good topic for it. Thank you. I appreciate it.
Be a good study.
Do we have any more questions? If you have any question, you can type it in the chat or unmute yourself. All right. Thank you, Dr. Coon. It's been a wonderful lecture and we learned a lot from it. And thank you for giving us the time to be here.
Thank you. It was my privilege.